I just want to take a moment to introduce you to the project team for this initiative. The project is being spearheaded by the California Healthcare Foundation, located here in Oakland. We work on the promise of better care for all Californians, supporting ideas and innovation that improve quality, increase efficiency, and lower the cost of care. I'm Kate O'Malley, Senior Program Officer, also joined by Katie Rodriguez, Program Officer in our Sacramento office. We are also joined in this initiative here in California by the Coalition for Compassionate Care of California, an organization that promotes high-quality, compassionate care for all Californians who are seriously ill or approaching end of life. It's a statewide collaborative of organizations and individuals representing healthcare providers, assisted living facilities, nursing homes, hospices, consumer state agencies, and others. Judy Thomas is the Executive Director of the Coalition. She is part of our presentation team today, and you will be hearing from her a little bit later. The Foundation is also ably supported and joined with Blue Path Health, a full-service, California-based health consulting firm working with government agencies, public health think tanks, health IT companies, providers, and payers to develop forward-thinking policies and strategies and improve patient care and community health. Timmy Leslie is here with me today. She will also be part of our presentation team and joined by Matt Mayanifin, a consultant, and John Weir, also a consultant with Blue Path Health. I'd like to take a moment to do a little bit of background on the project. So the California Healthcare Foundation began our investment in POLST program development in 2007 that has had both a state and a national impact. We've worked primarily with the Coalition for Compassionate Care and on POLST implementation in the state, which was formed as an independent, not-for-profit organization and works to facilitate uniform adoption of POLST through a network of 24 local coalitions. The statewide POLST task force was formed in 2008. This is a very large umbrella organization that brings together all members of the healthcare system and communities with an interest in POLST. We've also had representation and participation on the National POLST Task Force efforts. And in 2013, by 2013, the Coalition POLST Train the Trainer program had reached over 900 participants, mostly healthcare providers, and trained them in having the POLST goals of care conversation and how to train others in having this conversation as well. And the Foundation, of course, always looking for impact and value, did a survey in 2012 looking at acute care hospitals and nursing homes and found that 84% of hospital staff were educated on POLST, and 82% of skilled nursing facility staff were also educated on POLST. And we found that 54% of California nursing home residents had a POLST form. The phase one, which is where we are right now, these activities followed on the recommendations identified in the statewide POLST Registry feasibility study that we conducted earlier this year and completed in May 2014. During that time, we really looked at the California landscape to see whether or not a POLST registry made sense. And seeing some positive findings from the feasibility study, we launched phase one, which is where we currently are. So between now and the end of the year, the major activities during this phase are conducting a request for information process to identify the best fit technology and operations solution and really confirm some of the budget assumptions we made about what it would cost to do a registry in a state the size of California. We had a call this morning with the vendors who were interested in proceeding and exploring what that would take, and we'll be hearing later from them about their plans and approaches. The second part of activities in this first phase are working with candidate pilot communities to identify the community that can best fulfill the objectives of the pilot and will commit to sustain the program pilot phase going forward. And that's the subject of our webinar call today, is to share with you information from the request for information that was on the California Healthcare Foundation website about what it would take for a community to pilot this work in the state. The third aspect of the phase we're working on is to really educate and engage California state leadership, looking for active participation in the pilot and really helping us understand how a POLST registry in California would really support the goals that state leaders have for this type of work. So what we learn in this phase will really inform any next steps that the foundation might take, which could include initiating a pilot project in California that would bring an information vendor together with a community to do a pilot test of a POLST registry. At this point, I'm going to ask Judy Sitko to join us and walk us through the next couple of slides that will help continue to set the stage for the importance of a POLST registry in California. So, Judy.
Thanks, Kate. And this call today complements the one earlier that was targeted to potential vendors. Since we're targeting, our community partners here, I'm going to assume that a lot of you have already been working at a local level to really promote advanced care planning and POLST. But this slide is here just to remind us that the care that people get currently is not synced up with the care that people say that they want. And we have some great data that was collected by California Healthcare Foundation saying that 70% of Californians want to die at home, and yet you can see there on the chart that about 70% of Californians die somewhere besides home. So that's just a little bit of a glimpse into the need for a process, better processes to solicit, document, and make sure that people's wishes get honored. So advanced care planning is a process that happens over time, starting with when a person turns 18. We recommend that they have an advanced directive to name their surrogate, and that any preferences that they have about their values or goals or treatment preferences, that get documented in the advanced directive, reviewed and updated as their medical condition changes and their life circumstances changes. And then when a person gets to the point in life where they have a serious advanced illness, or they're medically frail, or kind of at that point where we wouldn't be surprised if they might die in the next year, that's when it's appropriate to have a POLST form. And so POLST complements the advanced directive, which is the patient's own document, just needs to be signed by the advanced directive, signed by the patient and witnessed by 2 witnesses or notarized. POLST comes in and it takes those wishes and it puts them into a medical order and translates them into specific treatment preferences based on that person's current medical condition, both diagnosis and prognosis. So POLST is part of that continuum designed for people who have advanced illness. So it plays a very important role, and because it's a medical order, there's one version for the state of California. It means a couple of things. One, as a medical order, emergency responders can honor it. And 2, because it's standardized, it's really ripe for a registry. Advanced directives would also benefit from a registry, but POLST has an even stronger alignment with the registry of having standard information go in and standard information coming out and that information needed in a split second. So you can see up here on this slide that there's other ways of documenting wishes, and that's just wanted to give you the context there for POLST. And now I think I'm going to turn it over to Timmy if she's on the phone.
Hi, everyone. This is Timmy Leslie. Thank you, Judy. And I think you're right that this seminar, webinar today is not going to focus as much on the POLST, but I will note that the new POLST form is available, and it is posted up on, or will be posted up on the CHCF site, and as well as it's on the Coalition site. So I urge you to look at the new POLST. There were a few changes that were made just recently, and it was released on October 1st. So the slide that we have here is orientation, again, of where we are in this project, and as Kate mentioned, the feasibility study was conducted earlier this year, where we looked at not only the feasibility of standing up a registry in California, but also looked to our neighbors as far as New York to understand some of their experiences and lessons learned with registry initiatives. At the end of the study, we recommended to go forward with the phase 1 that we are in now for us to better qualify technology vendors and opening up to all to give us ideas on how to take best advantage of new technology that's available today, as well as to work and identify with a community that would be able to stand up the initial registry. We will also be spending time over the course of the next several months working with state leadership to understand where and how the POLST registry complements the reform efforts. Once we go through this phase, we will look at our responses and make recommendations to the foundation as to whether or not they should go forward with the pilot. And if they do decide to go through with the pilot, we anticipate that the pilot would begin early next year. So the pilot phase is looking at really two major areas for us to be able to answer some fairly big questions. In the pilot phase, we're looking for technology that will be able to support the features and the required features of the registry that includes integration with electronic health records that are existing in the community today, as well as being able to support mobile access through tablets and phones. We are also very interested in ensuring that the registry is integrated into provider workflow, and that is including all of the stakeholders that will touch the POLST, which is quite exhaustive as the POLST follows the patient through different care settings. The third area of interest is really how does POLST fit into the EMS workflow. We've learned that EMS is organized very differently from community to community throughout the state. And so therefore, we know that the technology needs to be flexible enough to be able to accommodate different workflows as POLST is incorporated into those different communities. The pilot phase will also inform the financial modeling, as Kate said, confirm not only the budget during this phase, but also we will want to understand how to best maintain and scale across the state, and how do we tap into different funding, both public and private, in order to ensure the sustainability of the registry over time. In terms of the selection criteria, this is very much more detailed in the letter of interest. We're looking for a very strong community in the state that has experience with the POLST and the coalition, and also can demonstrate commitment of multiple different stakeholders to show that there is interest across care settings, and that when those that are submitting forms are also as interested in being able to access the forms. We will be looking for not only diverse stakeholders being part of the community, but also a diverse demographic, as well as having a demographics to support the population that's needed to have ample forms loaded during the pilot time so that we can test the viability of those forms. As I mentioned earlier, it's going to be important to ensure that we are working with electronic health records, both at the acute center as well as those that might be available in nursing homes. We want to be able to test different ways of inputting the data into the registry, some that are probably more elegant and others that are paper-based. And then also within the EHR, that is that integration can also have different levels of elegancy. And then finally, we want to be able to ensure that we have a named champion that's accountable for the project and the project team, and will be able to be present for project updates, be able to work with us on the evaluation, and be able to help the foundation make decisions around the scale of the registry and the timing of that. So this slide gives you a sense of an ideal POLST community. We decided to go ahead and put in a population number to give you some ideas of what we believe would be ample enough, as I said before, to support not only the population of the POLST, but also being able to test the access of the POLST forms. But I think that we should also really focus on the availability of the community to have different stakeholders at the table to ensure that the technology supports that workflow and also supports the different inputs and outputs. So we will be looking for communities that are engaging providers, provider groups, medical groups, acute hospitals, outpatient, skilled nursing facilities, hospice, and of course EMS services. That may include, depending on how the community is organized, fire, 911 responders, and ambulance. Also, we want to highlight that the community, especially when we are going through the feasibility study, there's definite interest from community or payer-based communities that have community-based payers, so local payers or Medicaid managed care plans that can help stand up the registry, participate in ensuring its success. So that's one area that I think it'll be really interesting to see how communities come together, not only the provider community, but also with their payers. Another highlight there, if we can just go back, that we looked at as a real complement to other dual programs that may be going on in the state. And so there might be a real complement there for other demonstration projects. Now I'm just going to change gears a bit and highlight other registries that are in place across the country. There are some that are more mature than others. Oregon's registry is definitely a model registry. It has been in progress the longest. However, it was built upon technology that wasn't available today, and they are currently going through a transition to be able to integrate more with EHRs and also to be able to have web-based access. On the other hand, New York has been working on a registry, and they have been using more today's based technology, but they haven't been working as long in the community or in the state, so they have a lower adoption. So when you plot the different initiatives across the country, of course California wants to stand out, and we are looking for not only having an aim high with our adoption rate, but we also want to be able to ensure that we are using some of the most advanced technology available as we build the registry. And what do I mean by advanced technology? What we're looking for is the ability to be able to support multiple ways of input and multiple ways of output. So on the left side of the screen, you see online entry through tablets or other internet-based, web-based forms. We also are looking for electronic health records to be able to facilitate the entry of these forms. And finally, we know that we have to have and support manual entry that will likely come through snail mail or fax, and we would have the ability to input those forms. On the right-hand side, we want to be able to have the ability to have a 24/7 call center so that those forms can be faxed where they need to be, but also that they can be available to the EHR when needed at times of crisis, and also could be pulled up either through web portal or through tablet or phone. In the middle, it is important to acknowledge that the registry has several layers of administrative functions. User account management and patient identification are two that are really highlighted, but also I don't want to lose the ability for the registry to link up with other registries or other research that is incredibly important as we think about population health and public health. And also the ability for the registry to have evaluation so that we can look at a dashboard and understand where there might be more penetration of POLST and more adoption of POLST, and where we need to put more, rolling up the sleeve effort for adoption. The next slide gives you a sense of how we're going about this selection process. The RFI was released, as you know, last week. We have our webinar today, and we're going to be soliciting Q&A. And then the response is due on November 15th of next month. We will be going through, reviewing the application responses, and then we believe that we will be calling through and selecting at least 2 or 3 communities to have sit-down conversations. And then really try to advance as much as possible of an understanding that if the foundation decides to go forward, what the roles and responsibilities would be for that community if they were selected. This is a recap of our timeline. As I mentioned earlier, letters of interest are due not on the November 15th, on November 14th. I believe the 15th is a Saturday. All of the information for the letter of interest is up on the CHCF website. We will also be, after today, posting up any of the Q&A that we have available. Once we have collected all of the Q&A, we will be closing that stage on October 22nd. And we will also be posting additional resources. If you go to the next slide, it includes resources of other organizations where we believe that you can find a lot of information around this initiative and other efforts. Surveys that have taken place over the course of the last number of years, and also the feasibility study that we referred to in this webinar will be posted there as well. So now I'm going to turn to some Q&A, and to get us started off, I have prepared, or the team has prepared a few of our most frequently asked questions that we've received so far after releasing the request for LOI. To get us kicked off, I'll ask the first question, which is there a set budget for the project? And no, the budget has not been determined today. We are going to use both the RFI that was released as well as this LOI to be able to guide us and give us input on a budget if we were to go forward, or if the foundation was to go forward with a pilot. Do you want to add to any of that?
No, just in case our terminology is a little obtuse, and the RFI is a request for information that went to vendors, and the LOI is the letter of interest that we're asking for from our community representatives. And combined together, that would really help us determine if we were to do a pilot project in California, what would the cost be, both for the technology and for any staffing required to really test the feasibility of a county-wide POLST registry.
And the second, thanks, Kate. And the second question that we have teed up is what time frame would the technology need to be developed? And I think this gives also a good sense for communities of how quickly do we believe that there will be a registry available to communities to test as part of the pilot. We would anticipate that once the technology vendor is selected, that we would have at least a prototype to be able to be stood up in a sandbox to be able to be tested by the community as well as the foundation within the first 2 to 3 months. And then it then would be released for use in the community within 6 months, and that the pilot would last at least 12 months after that, so a pilot of about 18 months end to end. What I didn't say earlier, which I'd like to emphasize here, is that using Oregon as a use case, they started with their pilot, and within 6 months the state passed a law that made it available statewide. So we could anticipate that any number of events might happen during that pilot phase. And so either after the pilot phase, we would then look to scale the registry community to community, and or we need to be prepared to be able to scale that registry across the state at literally a flip of a switch. Finally, the next question is, when will the state introduce legislation to implement a statewide POLST registry? You may be aware that there were 2 bills that were released earlier this year, both stalled in committee, but they both were looking at building and standing up a statewide POLST registry, and we anticipate that those bills, or a reincarnation of those bills, might be reintroduced. We don't know at this time. So I will open it up to questions.
Yeah, now it's your turn. We've given you lots of information over the past 20 minutes, 20, 30 minutes or so, and we'd be happy to take any questions. Am I still on mute? Yes, we actually have everyone on mute, and we are asking that you can use the chat box function on the WebEx platform to write your question to us. That helps us keep a log of all questions that we then respond to and we can share with others. So that was from, so David, if you have a question, please pop it in the chat box. One question that came in, can we have a copy of the presentation for this webinar? Yes. We have a recording of this webinar, and that will become available to us tomorrow. So at that time, we will put both the recording and a copy of the slides on the CHCF website where you found the announcement for the letter of interest for this initiative. And David, yes. Okay, well, I will read your evaluative comment. Thanks for this fantastic presentation. You're welcome. Very exciting. I'm looking forward to being part of this. First question, how will the foundation assist the local pilot community efforts? Well, what I would say is certainly working with the local pilots to identify the leadership team, to support the leadership team, to bring the information technology resources together with the health systems and the other healthcare providers at the community level to really provide the kind of technical assistance that would really bring together the interested parties. And once we move past phase 1 and move into a pilot test, there would also be money attached to these efforts that would pay for coordinating efforts and pay for staffing efforts. The exact structure of this we really have not determined, but there would be funding available to support the pilot communities to get this off the ground. Second question is, are you selecting the vendor separately from the community? Yes. The skills in the community and the skills of the vendor, if we could find one community that had both sets of skills, that would be awesome. But we're not anticipating that we will find both sets of skills from one particular type of organization. You may know, if you've been in the POLST world for a while, that the coalition and the foundation have been supporting 20 to 25 local community efforts to really help POLST penetrate healthcare systems, both hospitals, nursing homes, residential care facilities, outpatient locations where people with advanced illness receive their care. So there's a whole health system focus, and then the POLST registry really has very specific technical skills and requirements that also need to be met. We're not anticipating that a single organization could do both of those things. That's why we separated the technology request from the community request. But we would expect that the community and the technology vendors would be working together, obviously. That would be part of what a pilot would establish. We have another question. If our facility is interested but not aware of others interested in our community, how can this best be coordinated? Well, I would invite Judy to comment based on your website and how you've connected people in California to respond to this question.
Yeah, that's a great question. I think you could contact the Coalition for Compassionate Care, particularly Kelly Queel, who heads up our POLST work, and let us know that you're interested in what community you're in, and we will connect you to others that we know of who are working on POLST locally, and we'll see what we can do to help get critical mass going in your community.
So we'll do a little matchmaking then based on what we currently know. Here's another question. What happens to an e-POLST if the state does not implement a statewide POLST registry in the near future?
So we anticipate that the pilot would not just be a pilot and then end, that the technology would be able to support ongoing maintenance and operations of the registry for that community. So, if it does not scale across the state, we believe that the benefit of the POLST will still be there for the community.
Another question, are the LOI guidelines for community profile stringent in regard to the number of SNFs and hospices? I would say no, they're not. I think we're taking our best hypothetical guess about what we know about POLST penetration in populations and what we need to learn from a pilot to help us select the location that has the best chance of proving something to us. So if the numbers in a community are too small, they could be offset by a very high penetration, which would then give us the kinds of numbers we would need to test both the community engagement and also test the technology solution to e-POLST. So it would be a balancing act. If we're going purely by the numbers, we're saying 500,000 people with modest penetration could be sufficient. If we have very high penetration in a smaller overall population, that would get us to the same place. So it would really depend on what the most convincing case an applicant could make, saying, we may be small, but we're mighty because we've got, 4 hospitals and, 10 SNFs and, however the case could be made, we think the penetration would add up. So that would be my response, and I would invite Timmy or Judy to chime in.
Yeah, I think it's a great question, and we really struggled as to whether or not we even put these guidelines into the letter of interest, and we decided we should give some clarity on what it is that we are looking for, which is really a diversity of stakeholders coming together, because POLST, as I mentioned earlier, really touches so many different hands as the patient travels through different care settings. So we are very interested in learning as much as we can in this pilot phase to ensure that the adoption is maximized and fit into the workflow of these different entities.
Yeah, and I would just add to that, California is a very diverse state, and we have some smaller, more discrete communities, and then we have some very large communities that go on for very large geographic areas. I think we're open to any of those applying, and as Kate and Timmy have said, we're just really trying to find the best community that we think will be most successful in piloting, which includes, helping us figure out what are the challenges and finding solutions to overcome those.
Mm-hmm. Great, thank you. Thanks, Judy and Timmy. Let's see, we have another question, follow-up question. I was disappointed to see Senator Pan's bill stall in committee due to difficulty finding funding. Thinking very far forward, how do you see this pilot helping overcome this issue? It is also my dream to see a statewide POLST registry. Yay, you're on the right team. You're on the right call. Yeah, I think that is a challenging question, and I think, Judy, since you track a lot of the Sacramento stuff, maybe I'd ask you for a first response.
You know, I think funding was one issue, but it was not the only issue with both the PAN and the WOLC bill. And California does have experience with other registries that has been very, very mixed. There's been experience nationally and in other states with registries that's been mixed at best. So I think there was a lot of question about, is this the right time? Are the pieces in place? And frankly, the legislation is only one small piece of a successful registry. So I would anticipate that as the practical efforts like this that are looking at how to make something work, how to make a registry work as a practical matter, would definitely, several legislators would be, you know, aware of that and wanting to do what's appropriate within their sphere to help support that. And I think it would definitely help from a policy standpoint.
Great, thanks, Judy. We had one inquiry about the vendors who attended this call this morning, and this was an exploratory call, so I think we're not really prepared to provide a list of people who responded. These are basically technology vendors and health information exchange experienced people who were just trying to figure out what this was about. So we have no idea if their interest will translate into anything substantial. Okay. Let's see. We've exhausted the chat box, but we're still open for business for a few more minutes in case anybody has a late-breaking question.
Questions can be submitted.
Yes, I think in the LOI packet, there's also a space that gives instruction about continuing to cogitate and submit some questions to Glenda Paha, and her email address is at the end of the LOI. Or if you want to just write it down, or I can send it out to everybody who is who's on the call. I'll send you the address right now.
Kate, I moved it back one slide that has Glenda's email address.
Oh, okay, great. Thank you. Super. I sent it out as well. Okay, I think we might be done.
We're excited.
All right. Well, thank you again for your attention. It was great to have you on the call. Great questions, and we look forward to hearing from you in the future.
Thank you. Have a good day.
All right. Take care, everyone.
Thank you, everyone.
Bye-bye.